All right, good morning, everybody. We have 4 outstanding speakers, and we're short on time today. So appreciate all of you who made the walk over. So we're going to talk about the military pediatric response for Operation Refuge and all the refugees that we both took care of far and here at home. We have 4 outstanding speakers. Like I said, Dr. Parsons, Dr. Ferrara, Dr. Weber, and Dr. Rees. And we'll start with Dr. Parsons. So thank you all.
All right, thank you, everybody. And thank you all for coming in person today. I know the walk from the hospital can be lengthy, but it's beautiful outside, so hopefully you enjoyed it. So I deployed to Landstuhl, Germany in the fall to help with Operation Allies Refuge. One of my non-military coworkers told me that for as much as I complain about military acronyms, I sure managed to put a lot of them into my title. So apologies, but this was the Landstuhl Regional Medical Center response to OAR. Because of the high pediatric population there, of all the evacuees that we had, about 40 to 60% were children. So I was fortunate enough to really just be able to focus on pediatric care, which was a very nice privilege. I have no disclaimers. So I'm sure this is going to be echoed by everyone, but I could spend a full hour talking about my experience. So to keep it succinct, I'm going to focus just on 3 main areas. One, just to give you a little bit of context as to what was happening on the ground. I know we sent a lot of patients over to Walter Reed, and so hopefully this will give you a little bit more of an understanding as to what was happening on our end. 2 is to discuss some of the patterns of disease that we saw, and then 3, just some challenges. So the region of Landstuhl, Germany, if you haven't been, is actually comprised of a few different military bases. So there's Landstuhl here, which is a Role 3, like just traditional hospital. It's on its own base, kind of like Walter Reed. About 15 minutes away is Ramstein Air Base, and then further down the road is the Rhine Ordnance Barracks in Kaiserslautern. Both Ramstein and ROB took evacuees. Ramstein had about, I think, 26,000 total. ROB maybe had like 12,000. And both of these bases set up kind of immediate medical response teams to be able to provide some on-site medical care. ROB had a very, very limited medical capability. It was essentially a Role 1 maintained by family medicine, maintained by OB. They essentially had no lab tests they could do, and their medications were essentially limited to IV fluids and amoxicillin. So every patient I saw at Landstuhl who had come from ROB, essentially, they all had gotten amoxicillin no matter their illness. I was primarily in Landstuhl Hospital, which is a great hospital, but over the past several years, they have really gotten away from doing much inpatient pediatric care. When I arrived, the pediatricians told me that apart from the most routine bronchiolytic, they would otherwise refer their inpatient needs to the local German hospitals. Landstuhl Hospital does have a small NICU. It's got a fully equipped functioning adult ICU. And as far as like the pediatric response, so including myself, there were 6 general pediatricians. We had 1 developmentalist who was also there helping us out in the ICU, so no matter your specialty. And when everything was sort of ramping up, 1 Air Force pediatric intensivist and 1 pediatric surgeon from Lakenheath in the UK got in their cars to drive down. And then we did have some support from Germany as well. And then, sorry, to focus a little bit more on Ramstein, which had the largest population of evacuees. They basically housed everybody in temporary shelters on the flight line. And they divided these shelters up into 5 different units called pods. And then there was an additional pod of unaccompanied minors. Each of the pods had its own central medical tent where they were able to provide a little bit of care. So we had a little bit of a pharmacy, a few labs that we could do. And then in the gym on post, they set up EMEDS, which is an Air Force modular field hospital. And the EMEDS was able to do a lot of patient care. So they had overnight holding capacity. So they could do some procedures, they could do supplemental oxygen. They were very well equipped. And so really from Ramstein, we only got what was too complex for EMEDS to handle or what just needed kind of a higher level of care. This is what the pods look like. So this is where we saw patients at Ramstein. This is from pod 5, the patient census for a few days in early September. So you can see that they saw anywhere from 250 to 350 patients a day. This was the medical tent, not where we saw patients, but where the providers kind of rested. Over here in the corner was our pharmacy, a close-up which is here. So we had some Pedialyte, we had like some Motrin, we had a few different antibiotics that we could give. We even had some formula back when there was formula. But supplies were still very limited compared to the vast patient need that we had. So people would kind of be lining up outside the gate to try and come in to receive medical care. And so because the supplies were so limited, we ended up really trying to stretch everything as far as possible. So this, I think, is like mupirocin and nystatin dispensed, essentially aliquoted into a syringe and then handed to the families rather than giving them the whole tube, just to try and make that tube go a little bit further. So I really thought of the pods as like topicals, triage, and then transfer out to where else the patients needed to go. So again, this was the overall setup, and this is where I was. I'll be focusing on launch tool for the remainder. The timeline of how everything happened was starting on August 18th was when the first evacuees arrived to Ramstein. August 26th was when the bombing at the Kabul airport happened. It's also the day that I arrived in Germany. August 27th was the first trauma CAPT that arrived. We essentially had a mass call that day with all of the patients that they were unloading. August 29th, the director of the hospital came around and said that every single patient needed to leave the ICU within the next 1 to 2 days. There was a lot of fear that there would be further violence in Afghanistan and that we would be taking heavy casualties. And so our goal was to clear the beds in case we needed. So the first bolus of patients that I think of trauma patients that you got from us was under that context of we need to clear house fast. Germany was a little bit interesting in terms of the original goal for their response, but I mean the Ramstein launch tool kind of initial directive was to not have evacuees remain in Germany for longer than 10 days. And because of that, many of the other procedures that you typically do, like immunizations, vitamin A administration, prophylactically, weren't done initially. But unfortunately, the goal of getting people out of country as fast as possible really ground to a halt in early September. That's when measles broke out in the United States, and at the directive of the CDC, routine flights were suspended. About a week later, we had our first case of confirmed measles, but fortunately by this time we were already ramping up vaccination efforts. So we were really able to start vaccinations 2 days later. The pattern of patient needs really shifted throughout this kind of 2-month period. Following the bombing at the airport, a lot of our time was directed just at trauma care. And as we got those patients out and as fewer and fewer were coming to us, that really kind of diminished. Meanwhile, as people were there and living in crowded conditions for longer and longer, we started to see a higher burden of infectious disease. Meanwhile, patients with chronic medical conditions who had never before had contact with the US-based healthcare system kept sort of popping up to care, and then we would have to kind of respond to those as needed. So our trauma care, this is just kind of data from the patients who were in the ICU, so it does not capture all of the trauma patients we saw, including this patient here who was inappropriately triaged to the floor upon arrival and then was found to be a little bit altered, not staying awake, but mom was still feeding her and everything. There was no obvious entry into her head, but because of her altered mental status, we got a head CT which showed this projectile. So of our ICU level patients, almost half of them had some sort of orthopedic extremity fracture. Many of them had intra-abdominal injury, pulmonary contusion. We had several diffuse TBIs, and then highly significant penetrating injuries as well. Most of these ICU patients stayed for an average of 3 days with us. The infectious diseases that we saw predominantly was diarrhea and dehydration. This is a stool PCR panel that's representative of what we saw, and you can see it's almost like pan positive for all of the organisms that they tested for. So that was pretty common. When measles cropped up, that was where a lot of our focus was directed. We had typical skin and soft tissue infections, pneumonia, kind of other routine things, a little bit of malaria. And then the chronic medical conditions, which we were really, for the most part, ill-equipped to diagnose. And some of these patients you have seen and cared for and spent a lot of time with. But obvious to me that, or to us at the time, that there were very degenerative conditions. We had an unrepaired spina bifida, a kid with epilepsy who ran out of his medications, and then of course, births and newborn care as well. Some of the challenges, communication was such a big one, and communication on every front. So from providers to patients, from patients to their families, from command to providers and vice versa. Really, communication was just insufficient, but at times too much. So we had what we called a Euro chat, which was a WhatsApp group with all like 26 pediatricians from all over Europe who were kind of responding to it. And it was more rumor than not. Like the time that we heard that there was a plane of 300 children arriving and 30 of them were sick. Well, it turned out to be 300 people and 30 kids, and like no one was sick. We placed so much stress on our interpreters. There were not enough of them, and we got more as the time progressed, but heavy reliance upon ad hoc or just community-based interpreters who did a phenomenal job, but it was difficult. So I broached a DNI conversation with a not medically trained interpreter who did a phenomenal job, but that's a lot of stress on a person. And then this is an example of one of the patient documentations, actually a very good one. This is the sort of information we would get when they would arrive to launch stool via kind of whatever means they could. And we would get this nice handwritten note, which was sometimes pretty interesting and always had amoxicillin on it. One of the good things that came from this was I learned to rely on a lot of different people and learn to seek help. So Germany was very gracious and able to provide some support, both in terms of providers who were responding to some of the mass cal events when they were taking some of our more critical patients, especially before our intensivists got there. I became familiar sooner than I thought I would with the GTP, previously called PATH, and then of course being able to call all of the subspecialists to read. Another big take-home point for me, and one that I think we didn't do very well in the beginning and then hopefully got a little bit better at, was just the idea of pediatricians as advocates, which we're trained to do, in general, but then being able to take that into this humanitarian and military context as well. For example, mass or kind of large-scale vitamin A prophylactic campaigns never happened. We never had enough vitamin A. And that should have been, and I think it was by some people predicted from the outset, but that was not effectively communicated to leadership. And that was a failure on our part. I think there was some tension between what became the de facto goals of this mission, both the humanitarian care needs and then also this kind of military trauma response as well. And like everyone everywhere, we had so few resources. I was so surprised to feel that in Landstuhl, Germany, in this amazing rural-free hospital, that we couldn't always get what we wanted. So to wrap up, and so we can move on to all the other speakers, it was overall an amazing experience. There was a huge breadth of patient care. Myself and all of the other providers that I worked with, we really had to step outside our comfort zone. I'm not an intensivist, but I was in the ICU. The non-pediatric ICU nurses were caring for pediatric patients. I remember one time there was an adult gastroenterologist who was helping to kind of triage and settle in a 3-year-old burn patient and things like that. So it really reinforced to me what it is to be a military pediatrician, and that we are going to have to respond to things like this, and also to pass on to all of the residents, practice those skills, because it is very true that you may be in a situation where you are the expert and the person who's best at doing this. And finally, to everyone at Walter Reed who answered all of our phone calls and questions. Thank you. And for taking care of all of our patients that we sent to you as well. It was much appreciated. So thank you.
So hey, my name is Elizabeth Ferrara. I'm a pediatric nephrologist at Walter Reed, and obviously I've been asked to speak about this topic as well. So my experience was slightly different. I was in a much different area of the world. Okay, so these are my objectives. You can read them yourselves, and I'm going to say there's definitely a sense of theme that I think we're all going to be touching on as we walk through these talks. So I guess I'd ask first why all of you guys are sitting in the seat you're sitting in right now. Like, why did you decide to become a military medical officer? Why not just go to medical school and become a civilian pediatrician? And I would say those are very different ultimate long-term plans and goals. So some of it did it because you wanted adventure, others because there was a way to pay for school, others wanted opportunities that was going to maybe not be available to you wherever you grew up. Some did it for exotic travel, maybe others for family tradition, or maybe you did it for a variety of those things. Well, I will tell you that deployment definitely gives you some of those things all in one. So it's definitely an opportunity, adventure, and travel. So you already know what operationalized refuge is, so I won't talk about it. But I will say that it is important to remind yourself that you need to be a ready force at all times. Sometimes you get a warning order, sometimes you get to sit in a bubble and plan to go and get all your ducks in a row. And then other times you're heading out to dinner with your family on a Monday night and you get a call from your boss and say, hey, can you leave for Bahrain tomorrow for 7 months? And you're like, okay, yes, I can do that. But that means you have to have things pretty squared away. So there are the personal things you need to have squared away. You know, once again, I'm married and my kids are older, so it's not as big of a deal. But when you have little kids, do you have a way to make sure that they're going to be taken care of? And even your pets. You have your bills kind of sort of set on auto pay, your house, your car, all those legal documents. Are you ready to go if you get that call and you have a 24 hours heads up? If not, you might not need to start thinking about that. Logistically, are you ready to go? Have you done your PHA and is all your medical stuff current? Do you have a government travel card that you can actually like pull out of your pocket and take tomorrow? And do you have enough uniforms? And I will say that I am totally blessed. I didn't have enough uniforms for 7 months, but I am married to a fellow graduate of this program. So while I was running around on Tuesday doing my ISO prep and getting my papers signed and picking up the papers, he was off getting me more uniforms. So not everybody has that opportunity, but it's definitely helpful in this situation. And you need to plan to be expeditionary. Like we were in some weird little like secret squirrel base, which I'll talk about in a second. But we didn't know where we were going, or what we were doing, or what supplies we would have. So you need to be expeditionary, which means you need to be able to pick up your stuff and carry it. So if you can't stick it in 2 sea bags and carry it yourself, you shouldn't be taking it. So you need to pack for 7 months in 2 sea bags. So think about that. So they're your professional supplies. That's my list of the stuff that I think was important to take. Everybody has their own list, but I would start thinking about that before you go. I would say no self-respecting pediatrician is ever going to leave home without a Harriet Lane and an ophthalmoscope or an otoscope. But those are things that I felt like I needed. And then there are the personal supplies. So every time I've gone on deployment, someone says, oh, you don't need your passport. Every time I've gone on deployment, you need your passport. So I'm going to tell you right now, unless you are doing black ops, take your passport. Because invariably what happens is you go in on Mil Air and then you leave on Civ Air. And you're not going to get out of the country on Civ Air if you don't have a passport. And you're not going to leave anybody behind, which means nobody leaves. So take your passport no matter what somebody says. Okay, you need it. Make sure your cell phone SIM card is unlocked. If it's not unlocked, you're not getting a new SIM card in whatever new country you're in. And let me tell you, trying to reach back from Bahrain to San Diego or to the States to get my SIM card unlocked was not happening. WhatsApp and Google Translate. You should download those right now and keep them on your phone. And even if you're not using them, leave them there, because those of us who are far away may need your expertise and need to reach out to you. And I can tell you, your regular cell phone stuff doesn't work. So have WhatsApp ready on your phone all the time, even if you're not using it, because we might need to get in touch with you. Okay, so where is Bahrain? Once again, here's the Middle East. And then Bahrain is this little tiny island country. Can't get them out right there. Whoop. And if you mag it up, that's what it looks like. So Manama is the main city. We run a little secret squirrel base much further south. I will tell you, my husband's from Arizona, and he always talks about a dry heat and would say, oh, it's 120. My argument was 120 is 120, it doesn't matter. Having now been in Bahrain, I will eat crow on that one. So you can see here, it's 8 o'clock at night, it's 93 degrees, 73% humidity, and it actually feels like 122. And it got hotter as the night went on. And then on top of all that, when you're deployed, you have to have sleeves down, and then you're hot and sticky, and the wind is blowing sand at you. So you feel like a sugar cookie, but you're kind of sort of coated in salty, and it's not really a nice feeling. So I now will say I agree, a dry heat is a much better thing. So what was I a part of? So I was part of an individual augmentee med det. There were supposed to be 35 of us, but 6 people fell out. 2 fell out because they tested positive for COVID. 2 fell out because they didn't have their PHA ducks in a row, and 2 people fell out because they didn't have their government travel cards squared away. So like I said, have those things good and ready to go. So as a consequence, you can see those are the group of people that I deployed with. Based by rank, I became the de facto OIC. And I would tell you, it doesn't matter that I was an 06. You could be the leader at an 03, 04, 05 level. So be ready to do that and be ready to step into those shoes and lead, because that's actually a very important part of why we are military medical officers and not just doctors. And I would say you need to pick your leadership style. I'm kind of sort of a firm fan of lead by example. So get your hands dirty, be ready to work the long hours, and never, ever, ever complain down. You can complain up all you want, but if you complain up, you should probably go with the solution for what your complaint is related to, but do not ever complain down to your people. Expectation management. I truthfully think you need to expect the worst. So I was deploying with a bunch of those corpsmen who hadn't been in the military for more than 2 years. They'd never deployed and they had no idea what they were getting into. And honestly, I didn't know what I was getting into because nobody could tell us what we were getting into. So my advice to them was expect to live in tents, have no AC, no running water, expect to eat MREs for the next 7 months. And we're supposed to come back in March. So I said, if you get back by April, you should be happy about that. And the best part about setting those expectations is anything up from there is great. So then it actually puts people in a good psyche. And then share past experiences. So you can imagine if you have that massive pile of sea bags and you have to find your sea bags, looking for the little luggage tag on the handle is not particularly helpful. So you put your initials on the bottom of the sea bag when they're all piled up, and then you're like, oh, hey, there's my sea bag. That's so much easier to find. So share experiences that make life easier. And then be part of the team. So we were joining a unit on the ground. So we were kind of sort of putting ourselves into an already embedded unit. You need to be ready to work and work hard. As we showed up, one of the first questions from one of the people on my team was, when is my first day off? And I have to tell you, I spent the rest of my deployment trying not to be frustrated with that person. Don't go in with that attitude. That's not why you're there. Honestly, when you deploy, you do 2 things. You work and you work hard and you work out. That's pretty much it. So your day off doesn't really actually matter. And then learn ASAP about what you can have at your facility to take care of patients. And then most importantly, know the expectations. So just like Dr. Parsons talked about, the expectation was the Crown Prince of Bahrain was allowing us to use this space, but he didn't want to admit it to anybody. So his goal was people touch the ground and they get off the ground. So you may have had 10 days, they wanted like 24 to 36 hours and they wanted those patients gone. Our goal was to see the patients, make sure they were safe to travel, and then move them on. It wasn't about chronic care. It wasn't really about anything else. So in terms of supplies, so depending on where you are is going to depend on what you have. So if you see in this top box over here, that is the Interagency Emergency Health Kit. If you have not seen that before, that's put out by the World Health Organization. They're pre-positioned around the world. And it's supplies that basically are meant to provide care for 10,000 people over a 3-month period of time. It does not have the meds in it that you're used to using. But conveniently, that little green book comes in the package. And it tells you how to use the meds that are in there to do the things you're used to using. So be ready to be flexible. If you're in the military, obviously many of us are used to AMAL, so they're authorized medical allowance lists. So depending on your mission, there'll be AMALs assigned to you, but this wasn't really a planned mission. So we got what we had, which was basically a bunch of things, and you kind of sort of make your own pharmacy. And then you have up at the top what's called an RF box. And if you don't know what RF is, turn over and ask the person who's deployed next to you. And if not, you can ask me later, but I'm not going to say it publicly. But you have the RF box, which has a bunch of stuff in it, and it just is what it is. And then you learn to be creative. So anybody know what that is? I think you would probably call that a water bottle. I would tell you, this is my expeditionary aero chamber. Hole in the bottom, and voila, you actually have an aero chamber. Because I'm going to guarantee you, you're not going to have a regular aero chamber wherever it is you're deployed. And then also, what's this? You may think it's the tie to a mask. It's actually an umbilical tie after a baby's born, so you can tie off their umbilical cord. So be creative and be thoughtful. Okay, so my first call, well, not one of my first calls, I was the only pediatrician there. So one of the calls I got in the middle of the night, and you get it on the radio because there is no cell phone and there is no pager, was for a 7-year-old male who was presenting with an episode of decreased responsiveness. So you run into the tent, and we weren't allowed to take pictures. So a lot of these are stock pictures of various other things. Because once again, we run that weird secret squirrel base. So a small boy in dad's arms, he's limp, pale, and responsive only to noxious stimuli. The family says this happens every few weeks and has been recurrent since he was diagnosed with an infection when he was 5, for which he got antibiotics and steroids. In between the episodes, they describe him as basically a totally normal kid. But when these happen, he can't eat, he can't walk, he basically cries out on occasion. But they do see in between he has muscle pain and joint pain. You can see his vital signs there. His physical exam is really unremarkable, except for the fact that he's hypotonic and he's responsive only to noxious stimuli. And dad points out that he's smaller than his 5-year-old brother. His DEC 76. So you don't have access to labs. You don't have access to imaging. You do not have access to up-to-date. If you go thinking you're going to look stuff up, don't have that expectation because it's not going to happen. So your history is obtained through a fellow traveler, and although you probably had some, sounds like maybe a little bit more robust translation services, we had anybody else who happened to have been on the airplane that spoke English. So they know nothing about medical. And so it's very much like playing that telephone game in kindergarten. So what's said in the very beginning is never what's heard at the very end. So you're having to do things through these translations. So you think to yourself, what do I have? I have me, myself, and I have my education from USIS, because that's where I went to school. You have the ability to take a good history, and you have the opportunity to be a good critical thinker and put this all together. So what did I do? So I went back to the very beginning and kind of started this kid's story from his birth and kind of worked my way forward. Kind of sort of pausing on that infection that he had when he was 5 and his antibiotics and steroids. And I discovered he was having these reported episodes every 2 to 3 weeks. And so his provider in Afghanistan was giving him a shot of ceftriaxone, a shot of solumedrol, a couple of days of steroids, and then send him on his way. And he'd come back and this would cycle over and over and over again. So based on that history, with nothing else, I decided he probably had iatrogenic adrenal insufficiency. I put him on prednisone orally because that's all that I had. I wrote a long note. I gave it to the dad and I said, when you get off at the next spot, give this to a doctor who can actually do something more useful for you than I can right here. But this is what I had and that's what I did. So it is very important to be creative and thoughtful and don't depend on technology. So what about community standard? I think we would all agree that was probably not community standard care as we think of it, but it was community standard for where we were. It's all based on locale and your availability. So here's a 24-year-old male who's just about to get back on the bus to start a 14-hour flight to Washington, D.C. He came in saying that he was well until the morning when he woke up and he noticed that one leg was bigger than the other. He has no shortness of breath, no chest pain. And the security guard is yelling at me to hurry up because we need to get this guy on the plane because they can't separate the evacuees. They need to all stay together. And so his story is no different than anybody else. He spent many days in the Kabul airport not being able to really eat or drink. He ended up on a long flight going from Kabul to Qatar. He was in the Qatar evacuee camp until they put him on a plane to come to Bahrain. He was in Bahrain. He went through border security evaluation. And here he is now. What do I think he has? Well, I think probably he has a DVT and he's about to get on a 14-hour flight. Does that make me happy? No. Can I do a lot about it? Not really. So we didn't even have a measuring tape. So I took 2 pieces of plastic tape. I stuck them together. I wrapped it around the guy's leg and I marked the size of his left leg and his right leg. And I gave this to him. And I said, when you get to the next spot, give this to somebody so they can compare how things have changed. I wrote a note saying what I thought he had. And I went through my RF box and I found a slightly open blister pack of a Pixaban. So he went on a Pixaban. And once again, am I a pediatrician commonly treating DVTs in big people? No, but you know what? That doesn't matter because you do there. So there was his treatment till he could get off the plane and see another more formal doctor. Okay, so presentations of diseases in large displaced populations. Here's a 9-month-old who gets off the airplane with a cough and a temp to 100.4. Here's a kid who's an 11-month-old who gets off another plane who has a history of a rash for 1 day. What do I think those are? What can I do about it? Well, I get to use my clinical exam skills and try and figure that out. So I thought the first kid was measles. I thought the second kid was chickenpox. You can read those other things. The fact is, once again, they wanted people to touch the ground and get off the ground. So this was actually terrifying. This was probably my most frustrating experience of the whole deployment. Was that I was trying to convey to the leadership of the base, as well as the CENTCOM surgeon, that these patients shouldn't be set forward. But most importantly, the other 283 people on that airplane shouldn't have been sent forward, because as they sat there and rebreathed all that nasty air that they were spewing out at one another, we were potentially infecting a huge number of people. Now, I would never send Ebola into this country. Why would I send measles into this country? And I will tell you, this was a very frustrating experience because I talked repeatedly up various chains of command and was met by a brick wall because they all said they need to move. And I said, moving unsafe sick patients is not the right thing to do. So then you get to the question of like, what's your medical responsibility? What's your military responsibility? And what's your moral responsibility? And sometimes those things don't line up. And you have to figure out how you're going to handle this. So what's our number one thing? Our first thing is first do no harm. Our second is treat patients. Next is protect patients at risk. We follow our orders, we support the mission, but we still go back to first do no harm. So I met a lot of roadblocks on this thing. Unfortunately, I am old enough and if I turn that through, I could phone a friend at home. And so although I'm not advocating breaking chain of command, I will say in this situation, I felt compelled to. I needed to reach out to somebody to get in touch with Department of Health and Human Services and the CDC. And I think that is partly why those orders came on the 10th to stop patient movement, because they had already sent the other 283 people on that plane in different scattered planes to the East Coast. And then you can see shortly thereafter what happened. There were reports of measles being exposed in the Dulles airport. And I think it was probably from that particular case that I saw there. Okay, so my last 2 slides. So my comments are: be flexible, be semper gumby. There is no way if you go in thinking you're going to do it one way that's going to work out. Be creative. So be MacGyver. So, you know, a water bottle is not just a water bottle. It can totally be an expeditionary air chamber. Be knowledgeable. So we do internships, residency, fellowships, and we become very terminally differentiated little cells down there. But the reality is you need to constantly say that pluripotent stem cell. You need to go back. You need to take care of big people, little people, pregnant people. It doesn't matter. Be able to do all that stuff. Have contingency plans for your contingency plans, because nothing works out the way you think it's going to. Rise to the occasion. So if you're given lemons, make lemonade. And if you're, no matter what your rank is, be ready to rise and be the leader, because that's what you have to do as a military medical officer. And then whatever you do, do not depend on technology. It's not going to be available, internet, phone, it's not going to happen. I can't tell you the desperate phone calls I would make. I had like a 2-minute window where my phone was working, and I would call and someone would start going off and telling me about all the like interesting intellectual things about measles. I'm like, I get it. I don't care about that right now. I have a question, I need that answered. So if you get a call, answer the question. And then if you want to have like an intellectual discussion after that, feel free to do so. All right. And then lastly, volunteer. So although I did get that call Monday night to go for Tuesday, that morning I had sat down with my boss and I said, hey, if there's something coming, I am happy to go, please call. And sure enough, he called like less than 12 hours later. So I will tell you that if I had to do it all over again, I would have volunteered again. I would have raised my hand 10,000 times higher. I definitely would have gone. Our mission did not turn out to be 7 months. We ended up coming back much earlier. But if I had to do it all over again, there's not a greater people I would rather be with. And once again, you get experiences that you will never be able to otherwise kind of capture in any other way. And so when you're old and gray and you're telling stories to your grandkids and your great grandkids, it's not going to be about taking care of patients in garrison. It's going to be about doing stuff like this. So volunteer.
All right, good morning. I'm Zach Weber. I'm one of the neonatologists over at Walter Reed. And my experience was vastly different probably than everyone else's. I had a very large administrative and paperwork role, and I didn't see a whole lot of patients. So for me, it's more so trying to explain the role of a pediatrician when you're on these humanitarian missions, especially when you're not doing real medicine. Nothing to disclose. And then again, as I said, we're going to talk about what to do on a humanitarian mission and what to do when you're not actually practicing medicine. So I got a call on my wife's birthday saying that you were going to go to Fort Bliss most likely. Luckily, it wasn't right away. I had a few days to prepare my wife and family. And I actually did not go to Fort Bliss at all. I was at Fort Bliss, but went to their awesome range where they shoot tanks and stuff at Donna Anna, which is in the desert of New Mexico. So I spent the majority of my time in New Mexico at Fort Bliss in El Paso. So for those of you who don't know, this is Donna Anna. So there's a whole lot of nothing, right? There's really not a whole lot of structures. And in a very short period of time, we built a lot of temporary structures. We built a screening center. We built a urgent care area. But we were not really treating a whole lot of patients there. We were sending pretty much everything out to the civilians in the multiple hospitals in the El Paso area. So this is, I'm sure, and we also came up on the news a lot throughout the United States. But so this is what we looked like afterwards. So all these tents in these areas, these are all where patients were staying or refugees were staying. And there was even more than this. This was probably about halfway through the 2 months I was there. And it expanded even further. You can kind of see all the way in the back here where there's a little bit different color tents. That was our small little medical area where we did all of our screenings. We did not have a lot of room to screen the 10,000 patients there. So this is what we got. We landed on ground. We went to the site down and I saw these tents being set up. They're like, we're going to get 10,000 refugees. You're going to screen all of them. And they thought, you know, in maybe 2 weeks, we're like, that's not going to happen. But screening them is your health history, infectious screenings, all the vaccination, about 20 pages of paperwork. And we had to prioritize families with medical issues to get them out of there sooner. And then we supported, there was a lot of contracted civilians on the ground. We supported them to plus up their urgent care center. And the first week we were there, and then they had enough people. And then we just handled urgent medical needs that walked into the screening area. And a lot of times we just got them on an ambulance and sent them to the hospital. And then I think people mentioned this earlier. So about 2 weeks in, we never had an outbreak of measles, but a lot of the other camps in the country did. And from that standpoint, we halted everything that we were doing. So all these families who were in the middle of the process, we said, you're not coming back for several days now. You already have your vaccinations, but now we had to probably mass vax about 9,000 patients. In what they wanted done in a week, we probably got it done in about 2.5 weeks. We were seeing probably close to 700 to 800 patients a day getting them vaccines. And we only focused on, despite we had a lot of really young children who needed all their vaccines, just MMR, varicella, and COVID. And this was important, especially as a pediatrician, and I'll talk about this later. We are essentially public health experts. We do vaccinations all the time. A lot of the adult doctors don't really understand. Well, they're like, oh, everyone gets varicella. Like, no, they're not 12 months old yet. They can't get it. So we had to prioritize these vaccinations and really beat down that there's going to be a lot of people who don't have all the vaccines, and it's going to reflect on our records, but it's because of their age. And we had to do a lot of education with that and a lot of pleading with command that this is what it's going to look like and it's appropriate. This isn't a ding on us that we're not doing our jobs correctly. So yeah, like I said, well, what should we do outside of caring for kids? So I know we talked about Harriet Lane, but the Red Book, I think if you have a hard copy, bring it with you on those humanitarian appointments. They also have an app on your phone, which you can have and open up at all times. So bring it with you. And it's not just, oh, they have this disease, like, how do I treat it? It also talks about, do they need to be contained from other people and in quarantine? Can you quarantine them with other diseases? What do you need to do to treat these people? How long do you keep them in quarantine? So we started seeing, we had a lot of cases of varicella pop up, and we had to figure out what to do with those kids. And then of course, COVID, which wasn't in my Red Book that I brought down. But again, we had talked to the CDC about those kind of things, but then bring that, it's a lot of good information. Also things about what we need to know. And we were setting up the OB section for our camp with the contractors and saying, well, you need to be able to draw these labs, and this is what you need to do, this is what you need available if you deliver any kids here. Luckily, we only delivered 1 or 2 babies. Most of them were able to get to the hospitals in El Paso, so we didn't have to deal with like hepatitis B vaccines and vitamin K and things like that. But again, things to plus up and prepare for. And then of course, vaccinations. We know our vaccination schedules. We know our catch-up vaccination schedules. We had to tell them and how to prioritize what vaccines to give during these max vaccination campaigns. But then also when we're done and we're running out of vaccines, after we finish our max vaccine campaign, we're out of varicella vaccines, except for probably like 50 for probably almost a week, because all of our supplies were coming through Fort Bliss, and there was a nationwide shortage in a lot of these vaccines because everywhere across the country was asking for them as they were getting refugees. So I'm sure you guys, or Renuka probably had some of these issues too. So then they were like, well, we're just giving them to kids. And we're like, well, not all kids can receive these vaccines. So you have to vaccinate the parents, then, which was a big fight. But again, you have to kind of advocate for your patients because they're not always thinking about these things. Again, we keep reminding them that children are just not tiny adults. So again, I went online, we had a printer, so I printed all these out for our screeners, because we had enough physicians to like fill an MTF, but there was only 3 pediatricians. Everyone else was either like surgery or ER or ICU. So we made sure we printed all these out. They had all their vaccination tables, so everyone was well versed on what vaccines to give. And we also made annotations on all these. Who should we consider for other ones? Like you can give MMR down to 6 months for the measles outbreaks and things like that. So we made sure they had all of this information. Okay, and then the biggest thing, I think this is what I'm harp on the most, is because what do we do when we're not practicing medicine? Like I said, we did a lot of administrative work. We filled out a lot of paperwork. I spent a lot of time in the talk working with command on process improvements and how things were going on the ground. So again, in residency and medical school and fellowship, we always talk about quality improvement and quality improvement strategies. This is a huge thing, especially when we were doing something that's really never been done before. Our little Roll 1 tents were never set up to be a mass and a screening area for refugees to screen them to get into a country. This is the first time this has been done, to make like a Roll 1 to Roll 2 kind of area to do this. And there were a lot of issues from the start. Again, it was like no one area was talking to the other, paperwork was getting lost, and then families have to come through all over again. It was very, very inefficient. I think as a physician, we work with almost every part of the hospital on a daily basis. We work with patient administration, we work with pharmacy, we work with lab, We work with immunizations. So we're kind of the cog that would hold everything together and get these people working together, these departments working together in a more organized fashion. So eventually what we ended up doing, me and a pediatric pulmonologist from BAMC, we ended up creating a huge database to track everyone. And we ended up holding on all the folders and not pads. So we had we probably held on to about 2,000 packets at a time, just to make sure that everything was done, all the paperwork was filled out correctly. And we were the last people to sign it as well. Then we'd bring that back up the pad and say, give this to the NGOs so they can get them out of here. And so again, when that tried to get taken over by Big Army, we still kept ours, and when it failed, we always went back to ours. So again, there's things that you can do to help improve everything that works around you. And again, recommend workflow improvements. When you find that there are issues, just don't complain about them. Come up with a reasonable solution and bring it up to the command and say, hey, this isn't working well. These are the reasons why I don't think it's working well. And these are my recommendations. Please, can we try it at least for a day? And if the process starts moving better, we see more patients and get a better flow, can we continue it? And this is a lot of our putting our heads together as a physician team. And we made a lot of improvements and even changed locations of things in our area. We got more radiologists down there and whatnot. So we went from only being able to see about 200 people a day to up to about 600 processing paperwork a day. So we made a lot of improvements and being very open and giving our ideas to command, which they were, for the most part, willing to listen to and open to try. The next thing is teaching the medics and techs. A lot of these medics were right out of AIT. They've never really taken care of a pediatric patient before, or a patient who is 70, who are really hard sticks trying to draw these labs. So I taught them how to draw labs on babies. I taught them how to, for those of you who don't know, your vacuum tubes, when you're at altitude, don't pull out all the blood that you need. So you have to find a new way to do it. And they never knew. Taught them how to use a butterfly and a syringe to pull the amount of blood they need. They've never seen that before. This is something we do all the time in the NICU and in the PEDS ward, right? So just kind of think of the things that you can do to help everyone and get them through it. And so if you can make your techs better at what they're doing and their medics, it will help you in the long run, because you get the lab, you'll need to redraw labs, and they'll also get through there faster. You're also not, probably for the first week when we were doing things, I was in the lab area drawing blood with all the techs, teaching them how to do this as they rotated through. Once they were done, they were able to do it all themselves, and I was back in my administrative role getting paperwork done. And then again, I think as I echoed before, volunteer for leadership positions. No one really wants to sit in the talk and go through all these meetings and say what our deficiencies are, because it looks bad thinking that we're not doing a good job. But at the same time, being open and honest and giving feedback and giving ideas on how to improve the process will help you in the long run. So again, I got a lot of leadership opportunities during this time. Not something that I was planning on doing, but I think it helped me grow as a military pediatrician, as well as it also helped our mission move forward. And it also, once you have that leadership position, it gives you the ability to advocate. We're used to working really long hours, right? 80 hours a week, sometimes 100 hours a week if you're just on like covering for people. Your medics right out of AIT aren't used to working 80, 100 hours a week. When you're doing these mass vaccinations, it's not reasonable to try and do 1,000 a day when they're spending almost 15 hours a day, having to take the bus back to base and then come on back and then there's medication errors and things like that. People are getting the wrong vaccinations. And to mitigate these errors, we have to decrease the amount of patients we see and help them out so that they're not burnt out. It's a lot of times the first time they're seeing these kind of things, they just came out of training. So they were really worried, they're anxious, kind of scared because there's also violence in the camp. So getting in those positions really gives you the ability to advocate for your soldiers so that they are doing okay and not getting burnt out, not making those mistakes. So when they make those mistakes, they're really beat up about it. Again, that's another good thing about being able to take those leadership positions. And then last but not least, one of the biggest things that I was doing is just a liaison for the NGOs in the military. I was probably in a meeting with the Red Cross supervisor probably once, twice a day, once in the morning, once in the evening, about who we needed to see, who missed vaccinations, can we get them back to camp, who needs follow-up on labs, who needs treatment for abnormal labs, and or just patients in the very beginning who started and then we said, come back, please come back the next day so you can finish this stuff, and they just never showed up. So we, again, with our database, we were able to track those patients, but we had to work very closely with our NGOs to make sure we got those patients back so we can get them out of there, expedite them. So this is really one of the few pictures I took. My wife complains all the time I don't take pictures of anything, but these essentially are camps, right? So it's not a good picture because there was a big building on the other side of this where patients came in, then they came through here, got labs drawn, came through this little section, and then we did all of our paperwork here. That's about how big our tent was. And then there was a little walkway for another tent where they got all their vaccinations. So we did not have a very large footprint. We just had enough room to, put everyone through and get their paperwork done. Their average time there was probably once the max vaccination and, or at least for the paperwork to get done was probably a week to 2 weeks. We got all the paperwork done for them to enter the country. But again, when we had the stop movement because of measles, they were there for at least a month, if not longer, which gave us a lot of extra time to do paperwork, but we got it done pretty quickly. And then again, from that standpoint, we also advocated for movement because once we vaccinated them and then we were already way past the point of incubation period when they were still holding patients. So we started calling the CDC and asking for movement and things like that, which our command appreciated. But yeah, it was a really, really good experience. I learned a lot about how to be an administrator versus being an actual pediatrician. But yeah, no, that was how it was at Donna Anna.
All right, bringing up the rear. My name is Renuka Rees. I'm one of the general pediatricians at Walter Reed. And I'm going to be talking about my experience at Fort McCoy, Wisconsin during Operation Allies Welcome. And similarly, I had kind of a similar experience to Dr. Weber, but I'll kind of just give my personal spin on what our mission was, how we accomplished it, and what I learned. So just to kind of set the scene a little bit on how the first couple of days went for this mission for me. You arrive at Fort McCoy within about 48 hours, and this call you get on your birthday, and you arrive with one-way ticket because you also don't know when you're going to be going home. You kind of drive around the barracks, you figure out where you're going to be living, and you're unpacking your stuff, and you realize the packing list was very inaccurate because you're unpacking your very two like Army duffel bags with your Army sleep system and your Kevlar, and everyone else is unpacking their rolly suitcases and they have their fuzzy blankets and their reading lamps, and someone brought an Instapot. So not accurate. You're also, like some of the other people talked about, wondering what you're going to be doing, and you're meeting your teammates and they're also kind of wondering, hey, what are we going to be doing here? And eventually, pretty soon down the grapevine, you hear, okay, you're going to be doing these medical screening exams for their immigration packets. And so you're starting to learn, okay, what is that going to involve? There is no system to do this currently. So you and your team are going to essentially make a system from the ground up and accomplish the mission. And this is going to involve several things. So you're going to have to train all the providers to actually do the exam. What is required? What are the labs and vaccines that you need to do? You're going to figure out what supplies you need because right now you don't have any. And then you're going to order the supplies. And then you're going to figure out how to set up your space, which we had 2 old SRP buildings that were kind of empty, and figure out what the flow is going to be of the guests through that site. Are they going to come through one by one? Are they going to come through family cohorts? What are you going to do when there's 18 people in a family? There is labs and vaccines that are required. So how are you going to order those labs and vaccines and make sure each person gets the things that they need? And you're going to figure out a way to track all 12,600 of the Afghan guests that are at Fort McCoy to make sure who has gotten what done, who needs to come back and when. And you're going to start in 7 days, go. So this is definitely how most of us were feeling in the beginning, first couple of days, and kind of shattered any preconceived notion that I had that when you go on deployment, there's a very nice list of things you're going to do and everyone spelled it out. There's nice little check boxes. That is not how it is. Most of the time, you are the ones creating that nice little checklist for yourself. But we put our heads together and we started planning, and this is really how it started. So it was our team essentially sitting in the room in the beginning with a whiteboard. And I think right here, we're figuring out, okay, the guests arrive at our site, then what? Kind of what step by step is going to happen at each kind of section, each stop along the way. And then in this picture, This individual right here was from the CDC. She was the subject matter expert on the medical part of this screening exam. And this is kind of the group of providers that was with me, and we're all learning how to actually do this exam, what is going to be required. We quickly realized that a lot of vaccines were going to be given, and it wasn't just going to be the nurses and the medics. So here, one of our providers is learning how to give vaccines appropriately using a little Clementine. Some of our nurses put this workshop on for us. And like has been mentioned, we had a lot of pediatric patients and not a lot of pediatric providers. So how are you going to hold down a really feisty 5-year-old and give them 6 vaccines safely? And then once we finished our planning, we kind of started operations. And so we had our 2, this was the first site we set up. I say first site because halfway through, a group of civilian contractors came in and kind of took over this site for us. We kind of did left seat, right seat, where we taught them our process, taught them our system, handed the site over, and then we went over to a brand new site and set up parallel operations with them. And so this was our lab. Back here was all of our fridges where we had our vaccines, and then we had trained some of our enlisted soldiers to draw up vaccines. This was our lab area, and so we were doing quantiferons on everyone 2 and up, syphilis and gonorrhea screening on certain individuals, and then pregnancy tests for everyone who was of childbearing age, so that we could give them live vaccines. And then we ended up using all of that data to make a giant pregnancy tracker so that people who didn't know that they were pregnant or who became pregnant when they were on base, we could get them the prenatal care that they needed and follow up. And then kind of the last step of the process was getting all the vaccines to kind of your pod and giving them to the correct individual. So this provider here has, this is kind of a small batch, to be honest. Usually there were, 20, 30 vaccines per family unit. And then you're figuring out by individual who needs what based on their age. And so we did this for a couple of days. It wasn't perfect the first day for sure, but learned about the power of the AAR, and we did AARs again and again and again until this system was pretty smooth. We had a pretty good, well-oiled machine. And it was about at this time when we felt pretty comfortable that exactly what Dr. Weber was talking about. We realized we had 12,600 vulnerable people who were under or unimmunized and at very high risk for contracting and then spreading diseases like COVID, measles, varicella, and polio. And so those were the 4 vaccines we did for our mass vaccination, and totally shifted gears again and brought up a lot of the same questions we had in the beginning. What's the flow going to be? What supplies do we need? What are we going to do when one of these 12,000 people has anaphylaxis to a vaccine? Or if they syncopize, which happened not uncommonly, where are we going to put those people? And so similar questions, similar AAR process where we just made it better and better so that when we did our second mass vaccination campaign to kind of give those second doses, we had a pretty good system in place. And this is kind of just a close-up for in terms of our system. We had 4 giant warehouses, 1 for in-processing, 1 for out-processing, and then 2 in the middle for vaccine administration. And family cohorts would come in kind of in these lines. They would provide the urine sample in a porta potty. We made it work. And then they would get their vaccines kind of in these sections. And so we were able to kind of medically screen and get everyone all set from an immigration standpoint, and also do these 2 mass vaccination campaigns in a little bit over 2 months. And I think that really goes to show the strengths of the military in terms of getting us all there as quickly as possible, but also the team that I had the privilege of working with, which was incredibly dedicated and cohesive. So these are all the providers I worked with, the nurses, medics, the members of the 10th Field Hospital that we were all kind of augmenting. And in the front, you can see our interpreters who really, like others have mentioned, were just an invaluable resource. We could not have done this without them. So from all of this, what are the things that I learned? And I could go on and on about all the things I learned. It was like every day I was learning something new, but these 3 things I feel like really have stuck with me and stood out in my mind. So the first one was about the power of contribution. And I didn't really realize I had learned this until kind of I'd returned, and I was randomly listening to an interview by Liz Wiseman, who wrote a book called Impact Players. And while I haven't read her whole book, in this interview in particular, she talks about how important contribution is on a team, because people in general, when they're on a team, they want to be able to contribute. They want to make that plan better. And if you allow them to do so, it energizes them and it makes the plan work even better. And part of the leader's job is to really facilitate an environment that allows for that. and really encourages that. And luckily I had a leader that was like that and really utilized all of us, because in this picture you see we have a bunch of providers, but they're from all sorts of specialties. We have peds cardiology, pediatrics, sleep medicine, psychiatry, family nurse practitioners, and all from varying levels of training, where like just out of residency to decades of experience, but we all really did have something to contribute. And since we all really did make this plan together, we were very invested and we really worked hard to make it as efficient and effective as possible. And then from the leader's perspective, you know, it's not like he's done this before and he's like, oh, let me just draw from my experience of a mass evacuation of Afghan refugees. So you're not alone when you are put into that leadership position. You really do have this wealth of brain power and resources, and really utilizing that helps you and helps you get the mission done. And then the last two were really from just lessons looking at the population I was serving, which was the Afghan guests. So I'm not going to pretend that I will ever understand what that experience was like for them, but just really hearing their stories, it was truly horrific. You know, they are within hours notice leaving their family, their homes, their very established lives, and then coming to a country where they don't speak the language, they don't know the customs and courtesies, and they have no really certainty about their future. And yet, despite all of that, when they would come to our medical exam site and we would give them shots and draw their blood, they were nothing short of the most respectful and gracious towards us. You know, they would be saying tashakur or thank you again and again, even though we were kind of doing all these things to them and poking and prodding them. So it really helped me realize that, you know, this population can be that gracious towards us. There's really no excuse from my point of view, and a choice to be gracious and thankful. So when I found myself being, you know, sad that I didn't know when I was going home and I'm away from my family, I really did try to use their example to be thankful that I was given this opportunity to even try to make a difference. And then lastly, just a note on resilience. So this was really just by observing the Afghans and where they were. So you can see here, they're living in the barracks with us, like not with us, but in barracks very similar. They're doing their laundry on the base laundromat. They're going to the DFAC. They go to the next or the exchange. It kind of became routine to see them around base. You just kind of saw them walking around, said you waved hello. But really when you thought about it, and I paused to think about it, it really was not ordinary. Nothing about this situation was ordinary. But really they were continuing to live their lives and find some sense of normalcy. And I think it was really kind of more clear when you looked at kids, because we all know how resilient children are. You know, they would be making makeshift swings out of sheets. They're playing soccer with themselves or with the military police. They're, you know, playing amongst themselves. But even the adults who, you know, I think it's sometimes harder to pick up, obviously, and start a new life, they found a sense of normalcy too. They, you know, we're taking pictures in front of the fall foliage, taking selfies, going for morning jogs, which I thought was astounding. Like, who's going to exercise in a situation like this? But they did it. They went for picnics, they went for walks. So really, I think it's just a testament to their strength and resiliency. And so when I felt like, you know, you're tired of doing the same thing or constantly shifting missions, really using this as motivation to keep yourself focused and try to do the most good that you can while you're there. So just quickly, my take-home point. So firstly, really try to learn as much as you can from the people you're serving. I know it's not always going to be a humanitarian mission that you get sent on, but if you are working with a population with a different life experience and a different background, they have stuff to teach us, and really try to learn from them. Sometimes you have to build the plane while you're flying it. So this is definitely how I felt. You know, the Afghan guests are there and you are starting in 2 days and there's no plan. So it's not always kind of a cookie cutter recipe when you arrive. Sometimes you're making the recipe. Really tap into the experience and knowledge around you. Know that as a leader, you're not going to be alone in these situations. And then pack a fuzzy blanket, because you might as well be comfortable if you're getting deployed. All right, that's all I have. Thank you.
All right, so thank you very much. Again, I know there was a lot of military pediatricians out deployed doing various things. It was great to have our panel here to kind of show their experience and how it was unique to each one. Any individual questions for our group and for our panel?
Yep.
Originally was the goal to meet like the CDC based kind of outline for what immunizations needed to be for the Afghan travelers. And then upon the concern for a measles outbreak, then it shifted to just prioritizing measles, COVID, and varicella. And then it sounds like for you as well, polio. Is that kind of how that logistically occurred?
Yeah, from our standpoint at Bliss was, yeah, we were giving everyone every vaccine. So even if they didn't have any immunization records, they got all the vaccines. And then when we went to the mass vax, we just did those vaccinations. Then they had to come back and do the whole process, and then we'd catch up on all the other vaccines.
Okay, got it.
That was
And
the
then
same.
my other follow-up was then how did you keep track? Like what was the mechanism that you guys utilized in order to like find the amount of 10,000 people? And like, how did you guys do that?
So from what we did, Dr. Welsh and I, who is the doc from BAMC, we just kept an Excel sheet, and we literally each day we put in what family number came through, and if they didn't make it all the way through, where they stopped. And then once they finished their packets, we said when they completed their packets, and then again, if they were missing anything, we made another list of like who doesn't have vaccinations, this family group, and then what vaccinations they didn't have. Or if they missed labs or need to come in for treatment, then we had this family group need to come in for treatment for these things. And we had multiple spreadsheets.
And then do they have like a band on their hand? Do they have like a number that they knew? Like I'm number 375. Like how do you identify? You know what I mean? Do they have their packets with them?
The family had a card, and I don't know if it was the same for you. Did they have a card with a number on it? So our families had a card with a number on it, which was one numbering system. And then halfway through, they changed to a different numbering system. So some families had two different numbers. The newer families just had the new number. And so we had to which came a lot of issues from like the pad standpoint. We were able to link most of our numbers up, but they lost a lot of the other things, which is why one of the reasons we took over all the databasing, not pad, was because once they got the new number system, they lost all the old numbers. And so they couldn't cross-reference things.
That's so fun. What did you guys do in Wisconsin?
So surprisingly, we actually had there's a vaccine order sheet kind of on this packet. And so we would document kind of every time they came through our site on a new sheet, and we would give them a copy and then we would keep a copy. And surprisingly, they are very good at keeping papers that you give them, because a lot of them didn't come, they had forgotten their passports or their IDs. And so if you give them something to keep, they would come in with this huge packet of stuff saying, these are all the vaccines I've gotten. But then yes, like Dr. Weber said, we had a massive Excel sheet with pivot tables and all this stuff I didn't know Excel could do. Yeah. Yeah.
Can I just comment? So for the patients that we had, obviously they were not in the States yet, and their goal was to get to the States, which meant that they're willing to be forthright about a variety of things was not necessarily true, because they were concerned that if they said something or did something or didn't do something or didn't say something, that potentially would not be allowed to move forward. And so we did have armbands on the patients, but just like the armbands in the nursery that are constantly falling off the patients, they had big armbands to stick on little babies. And so that didn't work so well. So what ended up happening is they'd fall off and then they put them on the parents. So then they were truly like family units, sometimes of up to 18 people. So you'd have like one dad who had like 7 armbands. So which number applied to him and which applied to which kid, who goodness knew? It was kind of impossible to tell. But it did make trying to do the right thing sometimes confusing, because people didn't want to admit certain past health conditions or problems because they were still not stateside yet.
Hey, guys, the presentations were wonderful. Thank you for all that. I'm just curious, this is probably something you don't want to talk about, but how did you guys document? Did you document in Alta? Was there a system that was connected? I'm just curious about that.
So for us, we had no electronics. So no, we did not document at Alta. And many of the times there was very little documentation. They'd come in with, runny nose, colds, whatever, they would get some OTC type medicine. For the people who had more serious illnesses, we did write clinical notes, like the old fashioned paper SF600, that if you're old enough, you know what that is. And we generally took a picture of it, and just like you guys had talked about where you had that, the system where the Euro, whatever it was with everybody, we would send that to the entire camp. So all the providers would have documentation of that. And then we'd give it to the patient because like I said, my goal was when they showed up to the next spot, the translator I was worried about the telephone kindergarten game. And I figured if we wrote a fairly cohesive note that kind of sort of explained what we saw, what our rationale was, even knowing our limitations, that the next person could try and run with it from that spot.
Yeah, Ramstein and ROB kept pretty good paper charts on those SF600s, but whatever happened to them, I have no idea. They just sort of collected there, and who knows?
And when we were plussing up the civilian contractors, we just did SF600s, and then the base command took them into. So again, I don't know where they ended up, but that's what our docs were using.
Rees, I saw the various for McCoy. I saw there like 90 or 99.
Dr. Ferrara, I had a quick question for you. Sorry, can I just talk over it? You mentioned that you were at like this kind of like more super squirrely type place. Were there any challenges with calling back and trying to communicate all the information when you're trying to get consults and things like that? Were there any challenges with being in a smaller base like that with information you could or couldn't share?
In terms of getting back, there were several instances where I needed to call for advice and help. And so I frequently called either Dr. Lechner or Dr. May, and I said, I need a person who can answer this question for me. And then if that person didn't have WhatsApp, I'd say, hey, Dr. Lechner, Dr. May, can you tell that person to add WhatsApp to their phone? Because that was the only way I could get them. And like I said, half the time, even that comm went down and I didn't have it. So in answer to your question, for reaching out to people to get information, the limitations on the base related to electronic communication may have been because of the secret squirrely stuff. It's not super, it's a P3 base, so they do all the sub hunting type stuff. So they have aircraft. That's why you can't take pictures there because I don't want anybody to know what the aircraft look like. So they would shut down communications for a variety of periods of time for whatever reasons they were doing that. So we did have the ability to reach back, but with limited time windows, and you didn't know when it was going to happen. And like I said, it wasn't regular comms. It was, your phone if it worked at the moment you needed it.
Harry and Lena, the Red Book were the two resources y'all mentioned of very additional resources.
So I would tell you the military medicine humanitarian assistance course book from here should not leave home without it.
There's a PDF version too.
And download it. So once again, if you have your electronic thing, you have it. But once again, you may not have a plug to plug your electronic thing into. So I personally, as much as expeditionary, you got to carry it with you, I would still take the paper copy. The paper copy works whether your phone or electronic stuff does not work. So I would say that I actually took Sanford as opposed to the Red Book because I was really limited in space. And I figured that honestly, cooties are rampant everywhere. And although Red Book is more detailed, Sanford gets me the immediate information that I need right then and there.
And all the seniors, you guys will get a copy in a month in June when you take the course. So yes, freebies. My quick question is, we had heard rumors that it was difficult to know even the age of patients. Like what was the deal with that and how did you figure that out? And then secondly, about the cultural issues, like who was teaching you in those first few days? Did they actually have people that could tell you about? The other rumor we heard is that, male providers couldn't treat female patients. Was that true? And who taught you about that?
So for the age question, being a pediatrician was a huge advantage because I would use developmental milestones because it was usually like the infant age where it's like, is this 4 months or 6 months? Can they get which vaccine? And so I would ask the parents, can your child roll? Can they do this? Can they do this? And then sometimes I would just make a decision like they're 6 months, so you can give them MMR. And so that's kind of what I did because sometimes they had IDs or they didn't have IDs, but even the IDs sometimes were just totally inaccurate. Like this is not a 18-month-old, obviously. And then for the cultural situations, especially with giving vaccines, having to have the arm exposed down. So it really depended kind of on the family unit. And so we would kind of explain to them what we needed. And so some of them would want the male family member with them. Some of them just wanted kind of a sheet to kind of cover them up so that we had very open pods so that at least they had a little bit of privacy, but it wasn't a huge issue. No one ever like flat out refused.
From our standpoint, we didn't have too much of an issue with male providers, whether it was a tech or a doc doing anything. They were very open and willing because they were just wanted to get through this process and get into the country. From an age standpoint, our interpreters were fantastic. They knew the like the Afghan calendar. And so they would say, well, my child was born on this year in the Afghan calendar and like this month. And then they would say, oh, this kid is this many months. And so we'd be able to calculate it for us. So it was fantastic. A lot of times they'd also come in, a lot of the younger kids had vaccination cards from our standpoint. So we were able to they had their date of birth on there already. So we pulled out our phone and then put the calendar date from their calendar in there and we got how old they were. So we got lucky from that standpoint, but our interpreters were very vital in getting the correct age for us.
There's an online converter for the Afghan kids.
Yeah, we use that a lot.
So like I said, it was not infrequent that we would have families that were like 18 people. And it was pretty clear when you lined up who the mom and the dad were and all the kids that they actually were not all the kids of those two people. So when you would even ask somebody what their birthday was, they'd be like, I don't know. Or they would come up with some number and, once again, they'd say they were all their kids, but they had like a 5.5-year-old, a 6, a 7, a 9, a 9.5, a 10. Like, okay, that's just not. I may not be an OBGYN, but I do understand the whole concept of 9 months pregnancy. So there was, I think with the littler kids, you could use developmental milestones when they get to the point of like running around. And on top of which their growth was very different. It's not like you could plot them on a growth curve and say, oh, well, you're 50th percentile, so you're probably here. Because for many of them, they had a history of being malnourished. And so their growth was not comparable to the growth that we're used to seeing. So there was a lot of guessing. From my perspective, we had no cold chain, so immunizations were not really an option. The only immunizations after huge fighting I was able to get for the rest of the measles family, younger kids, because once again, they generally say that if you're greater than 6 to 10 years of age, you live in a country, you've already been exposed to it. So it was the littler people I was really focused. And since I could have very limited resources, my goal was to like protect the littlest people who were at the greatest risk for having problems. So I did get a few immunizations, but it was very specific situation.
All right, and the comments for chat was the developmentalists very happy to hear the use of developmental milestones and echoing what great presentation. So thank you very much.